Even though many patients feel that bariatric surgery marked a turning point in their dental health, and many dentists share this impression, there are still few high-quality studies in this area. One big challenge is that many of our patients don't see the dentist regularly. Early caries can be caught, but not if you only book an appointment once you have the symptoms. By then, it's usually too late to prevent it. Another research headache: caries doesn't develop overnight. Teeth has a lot of built-in resilience, they're made to last for a lifetime. So to document real changes in the teeth, you need studies that run for years. And because there are many factors beyond the operation itself that potentially can affect oral health, things like existing disease, medications, your oral hygiene habits, and not least your diet, researchers have to consider all of that. And here's how statistics work. The more details you collect on each patient, the more patients you need overall to run reliable analysis. Very quickly, good research becomes a question of funding. A smart shortcut to this is health registries. In Norway, your diagnosis and treatments from GPs and hospitals and any prescriptions you fill are recorded in national registries. Those data give a big picture view of population health and are a great place to look for associations. For instance, whether there's a link between bariatric surgery and other health outcomes. In Norway, and we're honestly world-class when it comes to registries, we've historically not been recording dental treatment. But luckily, Sweden has, and Swedes are pretty similar to us. They have recorded their population's dental treatment in Tandhälsoregistret, a dental health registry that's starting to teach us a lot. Let's look at 2 Swedish registry studies. Researchers at Karolinska Institutet published in 2024 results from a very large dataset. They tracked how much dental treatment people received before and after bariatric surgery among 53,000 Swedes who had either the gastric bypass or the sleeve gastrectomy. And they didn't just compare before versus after, they also compared to the general population. They matched each surgical patient with 10 controls, similar in terms of sex, age, and where they lived, because dental services varies geographically. The green line shows how much the control group, that's the Swedes who did not have bariatric surgery, received of different dental treatments over a 12-year observation period. The treatments were fillings, root canals, and tooth extractions. The orange line shows how much the future surgery patients received before surgery, up to what we might call year 0. And that tells us something important. Many people who go on to have bariatric surgery likely have worse oral health to begin with. In other words, a tougher starting point. But now look at what happens after surgery. Just visually, the trend is striking. Given the large sample size and the robust matching, this is a strong signal that bariatric surgery likely increases the need for dental treatment. Researchers at Karolinska also published another registry study in 2025. This time they asked whether the trajectory of dental treatment need was similar after gastric bypass compared with sleeve gastrectomy. And this is a nicely designed registry study. They linked multiple registries specifically to account for other factors that can affect oral health, not just the operation. For each gastric bypass patient, they found one sleeve patient who was closely matched on age, sex, BMI, education, income, relationship status, number of teeth, use of dental care in the 2 years before surgery, diabetes status, and also the use of saliva-affecting medications. In other words, 2 very similar groups of patients, differing mainly by type of surgery. Then they pulled the registry data on how much dental treatment the patients received, and they found that treatment needs rose after both surgical procedures, but the rise in fillings and root canals was greatest after gastric bypass. That's the black curve. This surprised the team, who had expected to see the highest need after sleeve. And while that hypothesis turned out wrong, it wasn't silly. We know that sleeve patients have a higher risk of reflux disease or heartburn. After a sleeve, many acid-producing cells remain, and the narrow tube-shaped stomach can even slide slightly through the diaphragm, sending acid the wrong way up. Acid damage can increase dental treatment needs, but still, the result went the other way. And to be a little critical, plots like this may make differences look big. In absolute terms, there was a 13% higher risk of dental treatment after bypass compared to sleeve. That may not have practical implications for choosing one procedure over the other, but it gives clinicians and researchers a reason to wonder about the underlying mechanisms. Registry studies have real strengths. They often have large samples, long follow-ups, and lots of contextual information, but they also have limitations. That's why we also need clinical studies where trained examiners assess the mouth using standardized methods. At the Sahlgrenska Academy in Gothenburg, researchers followed caries development in patients receiving 2 types of obesity treatment. One group was operated, bypass or sleeve. The other underwent a strict diet. Before treatment, there was no difference in caries between the groups. 2 years later, the diet group showed no progression, while the surgery group did show an increase. Those who were operated had more enamel caries and also more of the deeper kind of caries that goes through the enamel into the dentin. And since some studies do not find increased caries after bariatric surgery, it's fair to ask, what's different here? What sets the Gothenburg study apart is that follow-up was long enough for caries to actually develop. They compared against a relevant group, diet treatment, and they had a method for caries recording, which captures also early lesions. Taken together, these studies indicate that caries burden tends to increase after bariatric surgery, which strengthens the case for a possible causal link. So let me highlight a study from Brazil that asked whether prevention can help. There, all patients scheduled for surgery received an oral hygiene brochure and a soft toothbrush. They were then randomized to either a control group or a prevention program. And the prevention program included fluoride varnish every 6 months. And this is a high fluoride liquid that is painted on the teeth, plus tailored education on reducing acidic and sweet foods and beverages, and reminders about oral hygiene sent directly to their phones. The result? At 6 and 12 months after the operation, there was clearly less plaque and less caries in the prevention group. And that's the hopeful part. Bariatric surgery may well increase the risk of poorer oral health, but it looks like we can prevent a lot of it. And if you'd like to read more, we've posted summaries and links to selected studies on our website.